Hello, welcome to First Friday Fertility on Facebook. I'm Dr. John Preston Perry. I'm with Positive Steps Fertility and Periscope Fertility. Today we're going to actually, even though I'm happy, I'm smiling, I'm naturally that way. Today is a more serious topic. It is recurrent miscarriage. That is a topic that is incredibly painful. And even though I try to keep a sense of humor about everything that I do, and I know that's essential to sort of survive a lot of the difficult things. This is going to be a harder topic to have that get in. So I think I'm one of those people who even tends to smile sometimes when things are painful or difficult. But again, I'm trying to be upbeat about a serious thing that clearly matters. And I think this is a topic that even if you personally have never been faced with recurrent miscarriages, hey Amanda, even if you've never personally faced that, it's actually relevant. It's interesting that actually when you look at, first of all, we all know someone who's miscarried. These are really, really common. And we can actually say that a lot of the causes also, even if you don't know someone who's had it, hi Bryce, even if you don't know who's had it, a lot of the reasons for infertility, hey Tricia, I'm doing a lot of shout outs here. Love the people who are on. A lot of the causes for infertility that aren't explained actually can be evaluated through recurrent miscarriage workups. In fact, actually, this is something people don't talk about, but if you look at people where they've done an IVF cycle and they didn't get pregnant, 95% of the causes of why the person didn't get pregnant can either be figured out through a basic infertility workup or a recurrent miscarriage workup, providing you start incorporating the eggs. And we'll get into that. But I think we also care about it again because we have friends. We all know someone who suffered. Again, just 2 weeks ago, we had the Rainbow Baby Recognition Day. That's where we recognize people who've had a loss and then subsequently had a baby successfully. So many of us have suffered, and this is something that matters, and we need to get good advice for that. And now, just for a pause for a second, Cynthia's in the background going over things. We got to mute the volume here for that. Otherwise, I start getting feedback, and I'm hearing myself talk as I'm doing it. I say, boy, that's interesting. Of course, that's fascinating. No, adjusting a little bit there. So for looking at recurrent miscarriages, hey Kate, how are you? We have a lot of things that sort of matter for it. And I boil it down into about 3 main sections and then sort of 7 total subsections. But the thing is there a problem with the DNA? Hey Madeline, hey Heidi, is there a problem with DNA? Is there a problem with where a baby would attach in the uterus? And is there something going on for the bloodstream that could affect whether a baby will attach? Now, we're going to give, again, all the advice for things like, for instance, many people don't realize just normal statistics for miscarriage. If you're pregnant for the first time, never pregnant before, about a 1 in 8 chance you'll miscarry. If you've had 3 consecutive miscarriages and are pregnant for the 4th time, you have a 1 in 3 chance you'll miscarry. So almost triple the chance. Again, the way to think about it, first pregnancy, second with a previous miscarriage, third with 2 previous miscarriages, fourth with 3 previous. It's sort of going 1 in 8, 1 in 6, 1 in 4, 1 in 3. So that way you can give people good odds. But here's the other thing to know for that. A lot of people who've had miscarriages before, they will do well. Thank you, Heidi. They end up doing quite well, regardless of whether they have any testing or not. But the thing is, a lot of them are preventable and addressable, and you want to figure that out. So what is recurrent miscarriage? Recurrent miscarriage, you've had a miscarriage, and then you have another. That seems silly, but that's the definition. And by the way, a lot of people, at least OBs, only use miscarriage to refer to after 20 weeks. There are a lot of us who actually use it for referring to any pregnancy loss. There are 3 types of pregnancies that are excluded from that. Molar pregnancy, so that had some strange chromosomes, was very different, and that doesn't tend to repeat itself. Those don't count. Ectopic pregnancies, if it's a pregnancy in the tube that never had a chance, that's not considered a recurrent miscarriage or won't count towards it. And then biochemical, excuse me. Thank you. Biochemical pregnancies, by the way, most people don't know this about biochemicals, but they are ubiquitous. So they did studies in plastics companies in California in the 1980s. They had the first high-sensitive pregnancy tests, and they said all these women working in plastic companies were going to get these two-headed children and all these miscarriages and all these crazy things. And so they took all these women, whether they worked on the floor or administrative, and they gave them daily pregnancy tests. And they found two things that sort of surprised them. One, there were no two-headed babies and all this crazy stuff that they were worried about. And the second thing that surprised them was actually women got pregnant a lot more often than they realized, but just were miscarrying. If you do a daily urine pregnancy test, you'll actually find that about 40% of conceptions will miscarry. And a lot of them are just invisible. They dissolve, they break down, and it'll just go with a regular period or the barely missed period. And so it's interesting for people who are very regular, when they have a rare irregular cycle, sometimes that was a miscarriage and they just weren't aware of it. But we don't count biochemical pregnancies as part of recurrent miscarriage. Hey, Erica, we end up, just because they are so common and they aren't predictive as to whether people will do well or poorly in the future. So that's just one of the things to think about. So again, we are focusing on people where it's a clinically recognized pregnancy based on ultrasound or clear lab values that have sort of made it beyond that chemical range. Now, what can cause this? So you look at about really, again, the core things we said, is there a DNA issue? Is there a uterine issue? Or is there a circulatory or blood issue? DNA issue that normally is focused on the woman. Again, women are very important for all of life. They are the driving force for fertility and all of these other things. They also have more of a factor for this than usually male factor in fertility, which can, again, you can see a lot where guys have sperm issues, but at the same time, that's not usually a cause of recurrent miscarriage. But about 50%, by some estimates, of recurrent miscarriages, as well as failed IVF, again, relates to chromosomal issues that weren't detected. And so if you took every embryo going back, you actually see about, again, 80-90% of embryos failing to be mature or fertilize or develop or all those types of things for after you've gotten an egg in IVF. You see a lot that just don't make it because there was bad DNA or bad issues going on for it. And so if you were to do a biopsy and find which ones were chromosomally normal, you find a much lower miscarriage rate and you find a much higher implantation rate. So a lot of times with IVF, when you transfer an embryo and it doesn't take, it was because it was chromosomally abnormal. This is why pre-implantation genetic screening, I used to lean away from it. Now, as you start getting your mid-30s, late 30s, and certainly 40s, a lot can be answered, and that's really a source for many people when things don't take. So that's a driving force for it. There are also sometimes some rare things called balanced translocations or Robertsonian translocations, and this is where you have two pieces of DNA and it sort of migrated, and one half got stuck to another and the other half got to the other. That's sort of the reciprocal translocation. Robertsonian, you lose a little bit and you get abnormal numbers of chromosomes. Those are really funky things. Those are things you tend to see more with people who've had 3, 4 miscarriages, strong family histories of it. It's something that's relatively rare but can happen and be a driving force. Hey, Judy. Hey, Mandy. Hey, Lisa. Hey, Ertanami. So these are things that usually it's really hard to test. That's the one thing. The number one reason for recurrent miscarriages, most of the time you don't test for because it's really expensive. For doing the thing to find the rare balanced or reciprocal or Robertsonian translocations, those are things that often will cost about $2,000 per person. There are ways of getting it for less. We have connections where we can. But because it's such a rare cause of recurrent miscarriage, only 5% of recurrent miscarriages, you stay away from it. The majority of it, which is individual DNA damage, That's something that PGS does, and you can do that with IVF. But we tend to, hey, listen.
Simone says that she can't wait for her consultation so she can move forward with her post-uterine process.
Yeah, we're going to, that's a good thing. I want to talk about that for fibroids and adenomyosis. We will talk about that for uterine factor. I'm going to get to that actually next. A bit systematic because if I get out of order, I'm going to forget something. I want to avoid that, but I will come to that. Now, but the thing is, again, if you have to do IVF work, now again, for people where it's DNA damage and a source of recurrent miscarriage, it's powerful. We've had, I can think of a few people recently, 5 miscarriages, 3 miscarriages, things like that, where we were able to biopsy the embryos, find what was normal, put that back, and they're finally successfully pregnant after all these years of trying. It goes a long way. But at the same time, if you can get pregnant for free, and you sometimes have to power through it, and then the DNA was the source, again, if you can be economical, that's the perfect. Now, we just had a good comment, and now, by the way, this is a good point to step back and acknowledge something. When I'm doing these talks, this is all informational knowledge. This is general information. It may or may not apply to you. So even when I address Antonomi's question, talking about fibroids and adenomyosis, I am talking in general. I am not talking specifically about what she has said or posted because you can't comment on the internet about individual people. You have to do is general informational purposes and then talk directly to your physician as to whether it applies to you personally. Now, fibroids, adenomyosis, these things matter. The next most common reason for sort of recurrent miscarriages relates to the anatomy of the uterus, that it's not receptive to pregnancy. Adenomyosis is a complicated one, but at the same time, we do see lower pregnancy rates for that issue. In fact, in our national journal, I have a publication just in August, one of the lead articles talking about how uterine factor of fertility has to be evaluated and how adenomyosis can be relevant for things. Fixing it is complicated. Often people, that's one of the ones where it may be better to use hormones than surgery, but it absolutely matters. Fibroids is also addressed in that article. And by the way, any of you wants to go to figure out this article and read about how uterine factors matter, just Google fertility, sterility, and then Parry, P-A-R-R-Y, and hysteroscopy. You'll find the article. It is free for download. I made it publicly available. So any of you want to learn about this stuff, you can get what the doctors are reading yourselves. Just download the article. It's free as a PDF. For fibroids, fibroids can do bad things to fertility, but the fibroids are complicated. Fibroids depend on number, size, and location. And so I had a person earlier this week, she has 7 fibroids in the uterus. They are all distant from the cavity. They are having no clear negative effect, and their risks of surgery outweigh the benefits. There are other people who can have just 1 fibroid pushing into the cavity, and it's horrible for that. When you have submucosal fibroids, they can do an 80% lower fertility, and they can have 2/3 of pregnancies roughly miscarry. And again, it depends size, location, other factors. You want to get rid of fibroids. You want to get rid of infection, endometritis. And again, you can talk whether it's 20% for uterine factor or whether you put endometritis as its own standalone in the 5 to 10%. So if you pick this up, this is a chronic infection in the uterus that makes it so that the uterus is less effective. Doctors miss this all the time. I had a person today where I saw they had an infection in the uterus, and there wasn't even anything done about it. And they didn't know because a lot of people haven't learned to look or how to interpret it. And so this is really important that you get good counseling and good advice for things. And so we will be talking about that. But again, you can see septae, which are fusions of the uterus, and that has to be cut away. Fibroids have to be resected. Hormonal therapy can rarely be the right approach, but there's a preference for surgical removal for many people. Infections should be treated with antibiotics. Scarring through adhesions should be removed. There are multiple things that can be done to correct and improve uterine factor fertility. Let me just scroll down. I haven't responded. Hey, Lauren. Hey, Mandy. Hey, Ashley. A lot of great people. Hey, Vicki. Lauren. All kinds of great people. Thank you, Edna. You are so sweet to say that. I appreciate that. Hey, Bryce, Amanda, a lot of people. Hey, Hannah, I love all these people who are on. Hey, Candace. Okay, so now coming on for other things for recurrent miscarriages. After you've addressed sort of the ovarian or DNA issues, and again, rarely the sperm or for the DNA, the next thing you focus on is after the uterus is going to be lupus related. Now, the lupus related is only about 10-15% can run in families, but not always. But people have talked classically about hypercoagulable causes. Your blood clots too easy. People all the time are talking about prothrombin, factor V Leiden. To the best of my understanding, a lot of those have gone by the wayside. 10, 15 years ago, we were believing those more. Now we aren't doing those. And you note, and you read a lot of articles where people say, oh, I've got to take aspirin, I've got to take heparin to get pregnant, I've got factor V Leiden, and all those things. Again, they're exceptions, but most people actually don't. Remember, 15% of people will have factor V Leiden. And so the thing is, a lot of people are giving things that can cause them to bleed and have even an abruption or other things like that. Or if they were in a motor vehicle accident, they could have complications, and it wasn't helping their fertility. However, if you've got lupus anticoagulant, anticardiolipin, beta-2 glycoprotein, these types of things, this is where I think there's some good data that actually being on aspirin and Lovenox for low molecular weight heparin or regular heparin, these things can make a difference. And so if you have those things, definitely look into that as a cause of recurrent miscarriage for things. But that's, again, a little more rare. Next thing you start looking again gets to the endometritis. Classically, endometritis is an infectious cause. We used to think of the uterus as a sterile state, but actually what we find is that there may be an exchange between the vagina and the uterus. So if you find that chronic infection, it wasn't an STD, nobody should be blamed, someone has these things, but you want to get it treated to optimize fertility. And so it's kind of interesting. The classic approach is an endometrial biopsy, which is, these can be really unreliable. The new standard is I think, hysteroscopy, and I put that into the paper as well, read the paper. But then also, it can miss things. It only focally biopsies things. It may miss the infectious area. But more than that, you spend about 500 to 1,000 on the biopsy. You spend 500 for the pathology. And you know what it tells you to do? Do a $30 antibiotic. That's crazy. Most people should just get, in my opinion, and again, it depends on individual circumstances, you give a $30 antibiotic rather than doing a $1,500 workup to, say, take the $30 antibiotic, particularly if it's common. Back to dollars spent per pregnancy achieved, you got to be economical. That's what we're all about. How do you fuse common sense with evidence? And I think more people need to do that. Okay, next thing beyond that, again, is the rare balance translocations. Again, breaking things down. Ovarian and ovarian DNA, 50%. The anatomic, about 20%. Lupus related, about 10%. Another 5% is the balanced translocations or strange DNA patterns. Again, also picked up through IVF with PGS, or you can do other testing in advance. And then the beyond that, you really start looking at things like diabetes and thyroid disorders. Now, again, these should be rare, but you screen for them, and especially because they're so inexpensive. An A1C, TSH, these things are not bad. Now, A1C is out of control. For uncontrolled diabetics, they matter a lot. You see that actually when an A1C is above 11, you see a 30% miscarriage rate. When it's above 13, you see a 60% miscarriage rate. So you really want to have good glycemic control for people who have diabetes. And for diabetics, you're often talking, if you're back to 6.5, your risk for miscarriage and birth defects should be close to that of the normal person. And so that's the cutoff we tend to focus on for things. Thyroid, again, there's a lot of debate for thyroid issues, and it's certainly above 4, I think everyone's in agreement. Under 4, there's some debate. And again, you also want to watch for also cretinism, where it can affect the IQ if the thyroid is off. We have been going back and forth and are leaning more to a 2.5 to 3 roughly. We've more recently been to about 3 where we're treating for TSH. But again, some people can make an argument it's 3, 3.5, 4. It's kind of interesting. For the Endocrine Society meetings, people are very passionate where there's not enough data on this. And you'll have people that you can't imagine this with doctors, but they'll take each other out in the parking lot and beat each other up, arguing over the 3 versus 3.5 versus 4. People are very passionate about the reality is we need better data. And I think this is one of the reasons we need to fund science because, and this is not to get into politics, but here's the thing. A lot of science has been defunded as of late. And science is what we know. Politics is what we do. We have to inform what we do with what we know, not pretend we don't know to justify what we want to do. So I think as a society, we need to invest in research so that people can get good, effective care and get good results. But that's my brief soapbox for the moment. Go science. Okay, next, beyond checking the A1C and TSH, that's most everything. And the thing is, again, that will cover not only, again, what we've talked about. Again, we've said, is it an egg DNA issue, and is it for 50%? Is it 20% uterine? Is it 15, 10% for lupus? Is it 5% for strange DNA rearrangements, and then sort of in the 2s for diabetes and TSH for thyroid? And prolactin also, uncontrolled hyperprolactinemia can have an effect. There can be some really funky things that are also exceptions, but that will cover about 90-95%. And when you get, it's not just for recurrent miscarriage. If you look at people with, what's it called, failed IVF, if you've done those workups, you can figure out about 90-95% of why for IVF didn't work as well. So you want to do those things also.
Whitney Mullins is literally the best physician ever. Thank you so much for helping me get my rainbow baby.
I love you, Whitney. Thank you. Hey, Blakely, a lot of cool people seeing here. Hey, Hannah. Hey, Angel. Oh my gosh, all kinds of great people on here. Hey, Andrea. Hey, Jerusha. Ebony, Brienne, Hannah. All kinds of good people. You guys throw out some questions, by the way, for me. I've been talking about recurrent miscarriages for 20 minutes straight. And again, I tend to go off on my own tangents and things that I find interesting and are relevant. One of the things I think that people also want to know about is, you know what? What do you say when someone's miscarried? That's something nobody talks about. And first of all, I think one of the things people want to try to say, which is wrong, is, I know what you're going through. No, you don't. You want to say that. You're trying to be caring. You're trying to be empathetic. And we need empathy. But the thing is, everyone is suffering in their own way. And what people need to hear is not that you know what they're going through, even if you've gone through miscarriages yourself. Well, the real best thing is more to say support. I am there for you. I care for you. How can I help? And that's sometimes more valuable than anything else that can be said. The next thing that people don't need to do is give advice. You know, everyone says, oh, just don't worry about it. You'll be okay. You know, chance won't fix a fibroid that's in the uterine cavity. It won't fix balanced DNA rearrangements. Hope and prayers won't necessarily change lupus. And by the way, I think prayer can move mountains. I have to emphasize that. But at the same time, I see a lot of people where they've had infertility, recurrent miscarriage, other issues. And I think a lot of people say that if they aren't successful, well, they weren't praying hard enough. I don't think God hates those who have recurrent miscarriage. I don't think he plays favorites. I don't think any of these things. I've seen people with amazing faith have issues and people with horrible faith be completely fine. The reason I emphasize that is I don't want anyone blaming themselves or thinking that God doesn't love them simply because they miscarried or things didn't happen there. Sorry, again, you'd see I go on tangents. But I think this is important and is never said. Another thing that is not emphasized is, what do you do for people where they have an issue with it. And you know what the number one thing is? Say you love them, and then if they need support beyond what you can provide, get them to someone who can get accurate evaluation, who can treat them, and who can get them where they need to be. And I see a lot of people getting testing that really doesn't. You guys are often, having seen this, you're more educated than a lot of not only general physicians, but even OBGYNs, because I see a lot of things that are missed. And again, people are good at what they do. I always say, I lift the hood of my car, I can't find spark plugs, I don't look there. Many docs don't look routinely at recurrent miscarriage. You do have to find someone who does. But I would say also, do what you can to, if you have had recurrent miscarriages and are successful, and I've seen several people do shout outs here, give them the support and say, hey, I've been through this, it is possible. I'm here for you however you need. Scrolling down for things. Hey, Amber.
What about diet? Will going plant-based help with fertility?
Okay, good question for things. So, okay, and I see two things I've got in. Plant-based. So here's the thing. I believe in people being well for their own sake. You are what you eat. The baby is what you eat. And certainly if your food is suboptimal, that's less than desirable. At the same time, walk into any McDonald's. You'll see all these people eating horribly. They're surrounded by a litter of kids. Food won't make or break you. And again, we were hunter-gatherers for thousands of years, eating whatever we could find. There were a lot of issues for survival and nutrition. I think it is something that you want to be well, but the magnitude of effect for diet, it is less than 5% of the impact of recurrent miscarriage. So, and the reason I bring this up, don't beat yourself up. Similarly, obesity. Everyone says, oh, I weigh too much or I'm too skinny. Now, there are exceptions for where people stop having periods and they may need some progesterone for luteal phase support. That's a rare cause. That's with professional athletes. Obesity, you see from some data where it says a 10% miscarriage rate will take you up to 13%. That's a very rare thing. I would not put too much of your heart on the line for that. I think we tend to blame people who are overweight a lot, but as long as you don't have insulin resistance, it's far less of an effect than much of society would believe. Another thing they told you that you had a blocked tube. So this is something I talk all the time for, what's real for blocking, what's not. Tubal patency is complicated. You need good testing, and you combine laparoscopy, HSG, periscope for things. The tube is complicated. And what the thing is, you can say, here's an interesting topic. And that's for another day. I may have to make that November's one. October, we're already have committed, and we're doing that on egg donation actually for October. But November, I may do it on understanding the tubes. But the thing is, you can have the truth be somewhere in between, where you can have an open tube and then it's with one test closed on another. And sometimes you're wrong, it's spasm or pain or other things, but then it can also be damaged. And a damaged tube can be technically open but not functional. But we'll talk about that downstream for things.
Amanda Myers, I'm sure this has been asked already, but does birth control cause fertility problems?
So almost never. Great question. So here's the thing. Everyone is saying, oh my gosh, I've been on birth control pills. I have to be off birth control pills 3 months before I get pregnant. That is not true. Actually, the month you come off birth control pills, there's a slightly higher chance of twins. It takes you from about 2% to 3%. Where you watch for things for birth control pills or for contraception. So one, if you had Depo-Provera, it sometimes takes a year to fully get back to normal fertility for that. So we watch with that. But usually, again, 3 months, much of it's worn off. 6 months, you're getting closer, but it can take up to a year. IUDs, almost never, but I've seen people where the IUD has led to scarring in the uterus through a perforation or other complications. Most of the time it doesn't. Implanon, if you've still got it in and haven't removed it, or again, Nexplanon, there are all kinds of variations, but the point being, if you've still got it in and you can't stop it, that's usually not an issue. But for the most part, birth control is rare to cause fertility problems. Okay,
All right.
going down.
Hannah, Dr. Perry.
Oh wait, I got Trisha next. She was there. Possibility of pregnancy with timed intercourse or IUI if ovulating from an ovary that doesn't have a fallopian tube. Is it possible? Yes, it's called transmigration. About a third of the time to a sixth under some studies. The only way to know whether which tube picked up an egg from which ovary is if you have one egg and you get an ectopic pregnancy. So you get a single source for the egg, and then it's in a particular tube. And you see with ectopics, 1/3 to 1/6 are on the opposite side. That may not reflect the normal statistics because of the tubal issues, but it can happen. However, I would say it's inefficient if you're missing a tube. I have had people where they have one ovary and then missing the tube on that side, and then they're missing the other ovary and have the tube on that side. It's pretty hard for that, but it can happen for things. Hey, Pea and Devinder. Hey, De La Rosa. Okay, so progesterone. Low progesterone caused by PCOS. That is not true. Okay, or here's the thing, at least for my take on it. So first of all, low progesterone from a professional athlete situation or from IVF or from being in the mid-40s where the egg is dysfunctional, those things apply. But from PCOS is the problem is for getting pregnant because you're not ovulating, you're not releasing an egg, that's why the progesterone is low. The other thing is for PCOS, the miscarriages, when people talk about low progesterone miscarriage, that's usually the symptom, not the cause. When a pregnancy is not healthy, it doesn't make progesterone. Most pregnancies, when they miscarry in the US, and you can talk 80%, 90%, that's separate from recurrent pregnancy loss, but again, just talking in general for miscarriages, 80, 90% actually it's bad DNA. There was something chromosomally abnormal with the egg. And that's why you see a higher rate of miscarriage as you get older. If you are in your 20s, it's 1 in 8. 30 to 35, it's 1 in 6. 35 to 39, 1 in 4. 40 and up, it's 1 in 2 pregnancies miscarry. When they miscarry, they have low progesterone because things are dysfunctional. And so the thing is, people are having a miscarriage, they get their progesterone tested, and everyone says, oh, it's low progesterone. And they give them progesterone thinking it will fix it. If the reason for the miscarriage is bad DNA for that particular egg or sperm, giving progesterone won't fix the DNA. The DNA in an egg you were born with. You can't change that through hormonal therapy. Also, the other thing that a lot of people get wrong about progesterone levels is it changes a lot. You can see people in a 2-hour period go from completely abnormal to completely normal. It is pulsatile. This is the Philip Corey data from the 1980s where they put a central line into people's necks and sampled their blood every half hour to an hour to see what their progesterone levels were. And they found it was pulsatile and changed all over the place. So also, even drawing progesterone levels is unreliable. Okay, let's see. That was, hey, Heather, hey, Rachel. A lot of great people on. Yeah, lots of people can get pregnant with one fallopian tube. And again, if you do IVF, you can even bypass them. You can have no fallopian tubes. We get people pregnant where they have no tubes whatsoever. Okay, I think I've covered a lot. I actually have someone coming right in here for FedEx for something. We're having a live broadcast right now. If you could, just for a sec, just sign it off. But great seeing you guys. Thank you so much for coming on. We are going to do the next one in October, talking about egg donation, who needs it, and we will take also questions at the end of that. Come up with more for us. Write us and let us know how we can help. Good luck. I hope all of you who want to be pregnant are, and for those of you who have friends who have not been successful, help them along this journey. Again, the best thing you can do, especially for those that have made it to the other side, is let those who are suffering in silence know they're not alone. Thank you for watching, and we appreciate you guys.